Okay, I think we can start now. Let me check. Can you see me in full screen or not? Just the box.
No, we see you in full screen.
Great, then. Thank you.
You're welcome.
Okay, welcome everyone. Thank you for attending today's webinar. My name is Faride Pak. I am an assistant professor at Tehran University of Medical Sciences. This webinar is held by School of Allied Medical Sciences of Tehran University of Medical Sciences in collaboration with University of Trieste and also Italian National Institute for Nuclear Physics. This webinar is about X-ray phase contrast imaging, and Professor Renata Longo and Professor Luigi Rigon will be a speaker of this webinar. Just before we get started, let me to make some points. During the webinar, your microphone access and also your webcam access are denied. Then if you had any problem or any question, please write it down in the chat box. I will bring them up and answer if necessary. By the way, at the end of the session, we will have the question part for this webinar. Without further ado, let me to turn the time to our first speaker, Professor Luigi Rigon, and let's make some information about Professor Rigon. Professor Rigon is an associated professor in applied physics at the University of Trieste, and he's a member of Italian National Institute for Nuclear Physics. Also, he is a local coordinator of INFN research and development activity in applied physics, and he is member research group of synchrotron radiation for medical physics beamline at ELECTRA. Professor Rigon research activity includes phase contrast X-ray imaging, synchrotron radiation phase contrast breast computed tomography, and spectral imaging, and also single photon counting detector for X-ray imaging. Professor Rigon is author of 137 publications in international scientific journal with nearly 3,000 total citation and H-index equal to 38. Professor Rigon is going to talk about physics of X-ray phase contrast imaging. Dear Professor, it's your turn. Thank you.
Thank you, Farida, for the introduction. And I'm really excited today to give this talk in front of a very large audience. So I'm really glad to have this opportunity. So thank you, and thanks again to the organizers of this webinar. I guess you can see my screen now.
Yes, we can. Yes, we can see that.
Thanks. So yes, as you introduced, the topic today is X-rays phase contrast imaging. I will give a first talk more on the principle of the technique, and later Professor Renata Longo will give an overview of some applications. So let me start since the very beginning, since the famous discovery of X-rays by Röntgen. Well, one thing that really strikes me about this was that this discovery was immediately applied into clinics. So there was an immediate translation. Here there is a paragraph from the New York Times. It says that just 3 weeks later, it was successfully used in clinics. Well, now, of course, nowadays, more than 125 years has passed. Of course, we can say that the image quality has much improved. Also, the radiation dose has been substantially reduced. But another thing that is quite striking is that the physical principle that we use nowadays is the same that was used by Röntgen, namely X-ray absorption. On the other hand, we know that X-rays are waves, and this is also something that is very well known, but maybe yeah, is something disregarded, right? I mean, it has been well known also. This is, it took the title of the Nobel lecture that Compton gave in 1927, and the title was X-rays as a branch of optics. In the speech, Compton says that there is hardly a phenomenon in the realm of light whose parallel is not found in the realm of X-rays. So there is this idea that X-rays are waves, and if we want to use this idea, we should then model the sample by means of the refractive index of X-rays. So the sample is now a distribution of this refractive index. The X-rays are, here for sake of simplicity, a plane wave that impinges on the sample. And the sample somehow introduces some distortion in the wavefront. And this distortion is locally depends on the position on the image plane, okay? Now, the refraction index for in the X-ray regime can be written, typically is written with this formula. So n is equal to 1 minus delta plus I beta, where delta represents the real part decrement, is the phase shift, while beta, the imaginary part, accounts for absorption. And one important thing is that for low Z elements, I mean medical imaging, delta is much bigger than beta. So in principle, phase shift effect can be much bigger than absorption, than attenuation effects. So the idea is that we should use these phase shift effects to do imaging. And this is exactly the idea of X-ray phase contrast imaging. So the principle is that the object introduces a phase shift in the beam. The phase shift is indicated here with phi is a function of the object plane coordinates, x and y, while z is the beam propagation direction. And this phase shift can be written actually as an integral of delta along the beam propagation direction. And in turn, delta is proportional to the electron density. So now the problem is that normally this phase shift, even if it's quite a big effect, cannot be normally detected by detectors because detectors are not sensitive to phase, they are sensitive to intensity. So if you want to see this, you need some particular phase sensitive techniques. So techniques that are able to transform the phase effects into a modulation of the intensity on the detector. Now I will give a review of some of these techniques. But before doing that, since some of these techniques actually require some degree of coherence, so I want to spend just one slide about what we mean by coherence. To be honest, I'm not an expert, so I have quite a naive approach. Let's say that an imaging system has a certain degree of coherence if it can produce observable effects of interference or diffraction, for instance. So typically we distinguish between temporal or longitudinal coherence that regards the energy spectrum of the imaging system. And the idea is that the narrower the spectral bandwidth, the higher the coherence. And then on the other hand, we have spatial of lateral coherence. This is related to the source size and to the geometry of the system. And the idea is that the smaller the source size and the larger the source to sample distance, then the higher is the coherence. So a perfectly coherent system would be something that is monochromatic and a point-like source. The degree of coherence of a real source depends on how well these two requirements are approximated. And by the way, at synchrotrons, we are nearly in this configuration of a perfect coherent system because we have monochromatic beams and we have very small sources that are maybe 30 meters away from the object. So we have a very good degree of coherence. So let's now start the review of these phase-sensitive techniques. I begin with the simplest, that is called propagation-based imaging, PBI for short. It's also known as free space propagation or inline phase contrast imaging. And the idea is very simple. This is actually the simplest method, provided that the beam must be sufficiently spatially coherent, and also the spatial resolution of your detector must be sufficiently high. When these two conditions are met, the idea is you just have to take your detector and put it a little bit away from the sample, okay, at a certain distance. If you put it at a certain distance, during this distance, the phase shift introduced by the sample will propagate, and eventually you will collect on the detector a signal that is proportional to the second spatial derivative of the phase shift. So basically the Laplacian evaluating the object plane coordinates of the phase shift. As an example, I will show you the first image that we made. Actually, this is an absorption image. Okay, this is a mimosa flower. It was probably the first the first image that we made. I was an undergrad student at the time. It was 1997. This was done at the synchrotron. You see, this is one of these single flowers here. This is in absorption configuration, so with the detector very close to the object. You see something, but it's quite, I mean, the contrast is not that much, right? While if you just move the detector a little bit far away, this is the image that you get. It's a much sharper image because it takes advantage of this propagation of the beam. During the propagation, there is an interference between the beam that's being phase shifted by the object and the unperturbed beam here on the side. And this results in this edge enhancement effect. You see the difference is maybe at the edges. The edges here are very clearly highlighted by this edge enhancement effect. And this makes sense because, I mean, we say that we are proportional to the Laplacian. So the Laplacian gets big when we have some discontinuities, some interfaces, some edges, right? And so this is the kind of image we could get at the time. Now, this is another example. I took this from this publication. These are two human hairs, and there are several images taken at different distances. And here you can see that really increasing the distance, you really highlight this edge enhancement that gets bigger and bigger. I want to show you a first application of this technique. This application actually doesn't belong to us. It was developed by Marcus Kitchen and his group in Australia, the Australian synchrotron. So they studied a quite important problem. That is the liquid clearance in the lungs at birth. So they took a newborn rabbit puppy, and this is the radiography of the puppy just before it takes its very first breath. So this is 0 minutes, means that the puppet has not breathed air yet. Okay, so its lungs are still full of liquid, and actually they don't give any signal. You can barely see them here. While if you wait, for instance, 3 minutes, you see now that there are a lot of details, and these are the lungs that have been filled with air. So there is this liquid clearance, the air replaces the liquid, and you see after an hour you can clearly visualize all the airways. Here, this is the trachea, the bronchi, the bronchili, the alveoli, and you see all the lungs of the puppy. This is a very spectacular result, so I think we can spend some time watching this movie that shows the liquid clearance and the filling of air in real time during image acquisition. You see now all the airways here are getting clearer from liquid. And the idea is as soon as this get filled with air, you see them because you see the interface between the soft tissue and the air. And you see the interfaces are really clear here. So you really can, this is high resolution imaging, you go down and see all the alveoli in the lungs. Maybe I can skip now to the next movie. It's actually the same thing, but it's zoom. It's from the side. And again, you really see all the airways. And again, this becomes visible because they get filled with air. Okay, in the very moment that you have an interface between air and tissue, there the gradient, actually the Laplacian of the phase shift, it gets large, and then you can visualize it. You have this phase contrast. I show this image first because I think it's the most spectacular example of phase contrast imaging. And also this study had some clinical importance because despite being a study on small animals, it has some clinical consequences because he affected the guidelines of the International Liaison Committee on Resuscitation. I mean, by studying this mechanism, they decided that the previous guidelines were not optimal, and they changed it. They changed them according to the results of this study. Yeah, and the same group also does quantitative study. I mean, once you can track all the elements in the lungs, you can use these to make some post-processing. You can make some velocity maps, study the velocity distribution, and obtain some quantitative data that can highlight maybe diseases like cystic fibrosis and so on. I also now want to show a couple of slides from our experiment that we have done from 2006 to 2009. And this is an application of phase contrast to mammography. And this has been performed here in Trieste. Here you have a comparison between, I mean, we have the same patient at the conventional system and at the synchrotron. So here without phase contrast and here with phase contrast image. Well, you see here the phase contrast imaging doesn't look so spectacular as the one on the lungs rabbit. The idea is, I mean, there are several reasons, and basically is because here we had the lower spatial resolution. You know, in medical imaging, the spatial resolution is often related to the dose. So if you want to keep a very low dose, you cannot go too high to a spatial resolution. So this was our choice, actually. We gave at the synchrotron the same dose that was given at the hospital, so something in the order of a few milligrays, even lower actually at the synchrotron. And the idea was, if despite of this low dose imaging, we could see things better than at the hospital. And this is an example where when we could see things better. Actually, the interesting detail is this lesion here. If we zoom it up, okay, you see it also the conventional, but you see in the phase contrast, again, you visualize more clearly the boundary, the edge of this mass. And in particular, in this case, you see that the boundary is smooth. And this is good for the patient because it means that this mass was growing slowly without infiltrating the tissue. So it's probably a benign mass. Actually, it was a benign mass. It was confirmed later by follow-up. Here we have another case. Again, we have a patient with a doubtful diagnosis. There was this mass, but it was not very clear. So by zooming there, you see at the conventional system, the borders were rather in this, not very sharp, not very distinctive. While at the phase contrast, you can see really this infiltrating nature. Here in this case, the border is not round, is not smooth, but this is the typical appearance of cancer. Actually, there was a malignant tumor, as it was confirmed later by histology. So, well, you may wonder, well, if phase contrast imaging is so wonderful, why are we still using absorption imaging like in the times of Röntgen? Well, there are several reasons. Well, the first reason, as I told you, is that to do this technique, in particular propagation-based imaging, you need a high spatial coherence of your beam. And this is typically found at the synchrotrons, but not at conventional sources. You also need a high resolution of the detector because you need to detect this edge enhancement. And this can be also a problem in medical imaging because I was mentioning earlier, high resolution typically means also high dose. And if you try to implement this in conventional sources, you also have a problem of exposure time because if your source is not bright enough, the exposure time can be long. There was actually an attempt to implement propagation-based imaging into a conventional system. Say, there was an industry who realized a prototype that actually was capable of doing some edge enhancement, but probably the results were not so spectacular. And actually this machine didn't reach too deep market penetration. There is one more thing I would like to say about this technique is the possibility to add phase retrieval. To show you what I mean by phase retrieval, here I'm taking a very simple example. These are nylon wires. Actually, this is the absorption image. You basically don't see them, right? You see just noise. While if you use propagation-based imaging, you can see this signal that is proportional to the second spatial derivative. And so you see again very clearly the edges. And so you visualize these nylon wires. But again, you see just the edges. With phase retrieval, what I mean is a kind of post-processing that allows you to see not only the edges, but the bulk of your object. Here you see the contrast. I mean, basically what you do, you translate the contrast from an edge contrast to an area contrast. Okay, you extend the contrast to the bulk of your object. You lose maybe something in spatial resolution, but you can visualize the bulk contrast. And this can have some advantages. How can you do that? Well, there are several techniques. The more appropriate need to take images at several distances or maybe at several energies. But this, of course, is not very practical, particularly in medical imaging. But there are also some single image methods, single shot, so that you just take one image, one projection, and you can apply phase retrieval on it. Typically, you do some approximation, like you assume that delta is proportional to beta, or this is called phase attenuation duality, and you can process phase retrieval with just one image. And this is important. You see here, for instance, that we have, this is the propagation-based image. This is phase retrieved. You see again, you change from edge contrast to area contrast, but this can also bring some quantitative advantages. For instance, here we have some different materials and they look in different shades of gray because now we are quantitative. We are really mapping the phase shift, and the phase shift is different according to the material. So we have different peaks in correspondence to different materials. There are also other advantages that this transformation of the edge contrast to an area contrast also mitigates the influence of the noise. So you can improve the spatial resolution. And if you are doing tomography in three-dimensional methods, it also allows an easier and more precise segmentation, like in the case of this insect. Now, I would like also to spend some time on more sophisticated techniques because we have several. And now I will briefly review 4 of them: the analyzed-based imaging, edge-illumination, grating interferometry, and speckle-based imaging. All these techniques are capable of producing some parametrical imaging that reflect the characteristics of the sample. I begin with analyzer-based imaging because maybe it's not very popular because it can be implemented only at the synchrotrons, but it can be easy also, it can be useful to understand also the other methods. So in analyzer-based imaging, what we do is that we use a monochromatic beam that comes out from 2 crystals, and then we put an additional crystals between the object and the detector. So the image is collected after being analyzed by this crystal. The idea is that the object introduces some deviations here in the beam, and the deviations are very small. They're in the order of some 100 microrad, and they are proportional to the first derivative, so the gradient of the phase shift. Now, to understand how this system works, let us remove the object for a moment. And without the object, the analyzer basically reflects the beam towards the detector when it's just perfectly aligned to the monochromator crystal. So in this case of perfect alignment, you have the peak in this reflectivity curve. If you detune the analyzer even by a few microrad, the reflectivity rapidly drops to 0. And so you don't have the beam on the detector anymore. And according to this principle, if now, I mean, this can be, you see, according to this principle, it can be like a very powerful, a very effective anti-scatter grid. You reject the scattering because if you have some deviations here, they will be rejected. For instance, here we have a collimated beam that impinges on the usual nylon wire. The nylon wire opens, introduces some refraction. And now these refractive photons are rejected because they are not aligned with the peak of reflectivity anymore. Only the photons that are not being deviated are accepted. So the image on the detector will look like this. At the edge, at the boundary of the wire, where you have stronger refraction, strong deviation, you see black on the detector because the photons have been rejected. This is the so-called extinction effect. But you can also do something different. You can choose a working point on the slope of the analyzer. So now the things changes. If the photons are deviated on this side, they will find very low reflectivity, and so they will be rejected. But if they are deviated on the other side, they will find an increased reflectivity, and so they will be accepted. And so the image will look like this. One edge that deflects, let's say, the photons on the wrong way, it will be rejected, while the other edge will be accepted, so will look bright. And this is the typical image that can be produced. And actually, if you move on the different slopes of the rocking curve, you will have the opposite, okay, the opposite side that I speed up. And well, now I don't want to go too much in detail, but if you can take these two images and you combine together, you can also split the effects. You can have one image that just accounts from the absorption and the extinction of the photons, and the other that accounts for the refraction. And this is just an application, just one, because I don't want to run out of time. This is a femoral head. And this is the apparent absorption, so absorption and extinction. This is the refraction image. And I mean, typically, you know, it's not very easy to detect cartilage with X-rays. But in this case, we could see very well the cartilage, also the structure inside the cartilage. And another important thing is that here in the refractive image, you can visualize at the same time both the cartilage and the bone, and the subchondral bone and the trabecular bone below the cartilage. And this is very important because typically diseases affect the cartilage and the bone. So to be able to visualize them simultaneously can really be an advantage in the clinical environment. Yes, you can also add, I mean, this technique can be sensitive not only to extinction, absorption, refraction, but also to, this stands for ultra small angle scattering. Here in these samples, we put some scattering foils, and you see in the image, we could clearly see the different amount of scattering introduced by these foils. And this is ultra small angle scattering, I mean, in the order of a few microrad. Of course, I mean, also this technique gives spectacular image, but basically requires monochromatic and parallel beam. So it has been performed basically only as synchrotrons. There were some attempts to translate this to X-ray tubes. Here I put some reference. But the challenge is that if you move to a low coherent source like an X-ray tube, you really have low flux. And so you have too long exposure time, acquisition time, and that it gets impractical. So this is important because the next techniques that I want to show you, edge illumination, actually was developed in the order to produce images that were similar to those produced by analyzer-based imaging, so sensitivity to absorption, refraction, and ultra-small angle scattering, but without using crystals. And the idea is to use two masks instead. And this difference makes this technique applicable also at conventional sources, because no coherence is required. This was the very principle of this technique that was developed also in Trieste by Alessandro Olivo and us. And the idea is the following. You have a very thin beam that hits your detector at the very edge. So this is why edge illumination. You hit the detector at the very edge, and if the edge of the pixel is not sharp enough, you put a mask in front of it in order to have a sharp edge here. Now the beamlet is half in and half out of the detector. But as soon as the object arrives here, well, it will move this part of the beam that normally would go outside the detector will be refracted inside the detector. So you have additional intensity, you have a peak of intensity, and this is the white band that you can see in the image. The sample is the usual nylon wires. We use very often nylon wires to test these techniques. Then you scan the nylon wire through this very thin beam, and at a certain point, the opposite will happen. So the nylon wire will throw out photons that normally would have been detected by the pixel, will be thrown out. So you have a negative peak, which translates into a negative band here on the image. And you see this image is very similar to the ones that we have shown before with analyzer-based imaging. So basically, we are now sensitive to refraction and also to ultra-small angle scattering. The idea is that this principle can be implemented also a conventional source with a diverging beam. Then you need two masks. The first mask produces several beamlets, and the second mask that is just in front of the detector creates for each one of these beamlets this edge illumination condition. You see, the detector mask will create this sharp edge here in correspondence to a pixel of the detector. And for each pixel, you will have the same edge illumination condition. So you will be sensitive to refraction. Now, this is, okay, looks rather complicated, but it's feasible. You need to create this mask with a aperture in the order of 10 100 microns, which is feasible. Also with lower absorbing substrates, for instance, graphite. And the idea is that then if you scan the sample mask, the mask that is before the sample, you can just scan it and you can obtain different illumination conditions. Like it's more or less the same thing when you tune the analyzer, okay? You change the relative displacement between the two masks and you can have all the different positions on this illumination curve. So the nice thing of this technique, he has modest mechanical requirement and basically no spatial or temporal coherence is needed. So you can apply it to conventional X-ray tubes. There is another technique that somehow looks similar. There is grating interferometry, but it's quite, I mean, it's conceptually different. Anyway, also grating interferometry produces the same images like absorption, refraction, ultra-small angle scattering, but without using crystals, and it uses two gratings instead, a splitter grating and an analyzer grating. The setup is like this. So you have the object first and the two gratings. It may look similar to edge illumination with the two masks, but it's different. I mean, this is an interferometric techniques. You use the fact that the first grating, which is a phased grating, so introduces a phase shift, will create what is called a Talbot self-imaging effect. So it will create at a certain distance a periodic fringe pattern. This periodic fringe pattern is a very short period. So in order to detect it directly, you would need a very high resolution detector, but you can analyze it with another grating, a second grating that you put there just in front of the detector. And we call this analyzer grating. This is an absorbing grating that can reveal this high spatial frequency fringe pattern. You can, again, either scan it or maybe put a slight misalignment, so in order to reveal a more rare pattern. Now, I don't have the time to go into details, but the important thing is that this principle can also be implemented with spatial incoherent sources. I mean, this is an interferometric technique, so in principle, it needs coherence. But if you have an incoherent source, you can put an additional grating. This is the so-called Talbot low interferometry compared to Talbot interferometer with coherent sources and Talbot low, interferometry if with incoherent sources. You just put an additional grating here. And this grating creates an array of individually coherent but mutually incoherent sources. And within certain conditions, these images of the several incoherent, mutually incoherent sources add to the image formation. This technique also has been quite successful. Compared to edge enhancement, is a little bit more demanding in terms of mechanical precision, because this grating you see have a rather narrow pitch. They're in the order of few microns. And also they have a very high aspect ratio. So this is the phase grating and this is the absorption grating. Particularly the absorption grating is not very easy to fabricate, to produce. Now, I'm almost run out of my time, so I will go very quickly about this last technique, that is speckle-based imaging. This has been rather recently introduced. And the idea is completely different, is that you have your beam and before your sample, you put something that will create a strong speckle pattern. Something like this, okay, just speckles. Well, this speckle pattern will probably hide the image of your object. You won't see your object, you will just see speckles. But the idea is that if you compare this speckle pattern without the object and with the object, and if you are able to computationally track all these changes in the speckle distribution, then again, well, there are some details. Again, you can be sensitive to absorption, refraction, ultra small angle scattering. And you see, so you can produce all these parametric images. So this is also, this technique has been very recently introduced, but it's very interesting because, it doesn't need anything, it doesn't have particular requirements and can be easily performed also with some X-ray sources. And also the diffuser that you use to create the speckles can be as simple as a sandpaper foil. So it's very easy to implement. So this is my last slide. I just gave this quick overview through several different phase sensitive techniques. There are even more, but I didn't have time to go through all of them. So in particular, I wanted to stress, the role of propagation-based imaging and also with the option to add phase retrieval. And then there are all these, let's say, more sophisticated techniques. The last three in particular can be easily implemented also in conventional X-ray imaging sources. So they are, I think they are quite promising. Probably they could be translated in the near future to clinics or at least to small animal imaging applications. But yeah, about the applications, we will have Renata's talk later. So I think I can stop here at the moment. I see there are a lot of questions. So maybe I stop sharing my screen. If this system will allow me. Okay.
Okay, thank you. Thank you, dear Professor Rigon. Thank you for your nice presentation and your valuable insight on X-ray phase contrast imaging. I think if you agree, we can postpone the question for the end of the Professor Longo session.
Yes, why not? Yeah, no problem.
Okay, great. Great. Our next presentation is by Professor Longo, but if you agree, let's have a 10 minutes break, and then we will return to our second part of this webinar.
It's okay. Absolutely.
Great. Thank you. Then just 10 minutes break and we will return. Thank you, everybody.
Okay.
Okay. Welcome back, everyone. Our second session is starting. At this part of the webinar, dear Professor Renata Longo will make her presentation about application of X-ray phase contrast imaging in medicine with focus on mammography. Let me to give a brief description of Professor Longo scientific activity. Professor Longo is a full professor in applied physics. She is a director of the Master of Advanced Studies in Medical Physics, which run jointly by the Abdus Salam International Center for Theoretical Physics and the University of Trieste. Her present research program is phase contrast breast CT, which include toward a clinical study with synchrotron radiation, a single photon counting detector for medical imaging, and quantitative spectral imaging. Also, Professor Longo research program is on dosimetric model for X-ray breast imaging, which include development of a new breast dosimetry method and also development of a new breast dosimetry phantom, which is in the framework of AAPM e-formed task group. Professor Longo's scientific responsibility is coordinator of medical physics group of University of Trieste for the clinical mammography program in cooperation with Electra Synchrotron Radiation Laboratory and Trieste Hospital. From 2014 till 2019, she was national coordinator of the INF program in phase contrast breast CT in collaboration with Electra Synchrotron Radiation Facility in Trieste. She is also member of the AAPM task group with title of development of a new universal breast dosimetry method. And also she's member of the APM task group with title of development of a new breast dosimetry phantom. Professor Longo is author of more than 180 publications in international scientific journals with more than 4,000 total citation and H-index equal to 32. Over to you, dear Professor Longo.
Thank you. Thank you very much for your kind invitation for the organization of this webinar. I'm very excited of speaking with such particular and international audience. Let me share my oops. Okay. Well, thank you very much. I would like to spend my time in order to present you some medical imaging application of X-ray phase contrast imaging. I will spend the first part, sorry. Okay, I will spend the first part of my presentation showing you some results obtained in Trieste at the Electra Synchrotron Radiation Facility. And the second part of my presentation will be about translational research using a conventional X-ray tube in order to apply these techniques in the hospital. So this is a view of the Electra Synchrotron Radiation Facility. The synchrotron radiation facility is combined with the free electron laser source. So we have Electra, that is the synchrotron, and Fermi, that is the free electron laser facility. And here you can see Trieste. Trieste is here in the map. We are on the border with Slovenia, on the Adriatic Sea, that is part of the Mediterranean Sea. We are 2 hours by car from Venice. And it's a very nice place. And I hope to meet you in Trieste. Sometimes we have in Trieste, we have also the Abdus Salam International Center for Theoretical Physics, and we have after COVID and before COVID, we have a lot of activities about workshop and training about medical physics under the umbrella of the Atomic Agency, and so I mean that will be opportunity for a lot of you for coming in Trieste. But thinking at the synchrotron radiation, synchrotron radiation is the ideal source for phase contrast imaging, since the synchrotron radiation is due to the relativistic electrons that run into the ring, and the obtained radiation is characterized by a very large spectrum, a broad energy range spectrum at very high X-ray intensity, which means that it is possible to obtain tunable monochromatic beam. This is a sketch of the monochromator. Here we have the white beam, the polychromatic beam that arrive on the surface of the monochromator that in our beam is a silicon 111 crystal. Well, thanks to the Bragg reflection, we obtain that the reflected beam is monochromatic, and the energy of the reflected beam is due to the angle between the white beam and the surface of the monochromator. So changing the angle of the monochromator, we change the energy, we tune the energy of the beam. Moreover, since the beam is due to the acceleration of the electrons in the ring, we have that the geometry of the beam is a laminar one. So which means that in order to acquire images, we have to scan the object in front of the beam, or we have to rotate the object into the fan beam, as usually we do in computed tomography. The distance between source and sample is of the order of 20, 30 meters. So which means then even if the dimension of the source is comparable with the source of the X-ray tube, the distance between samples and source is so large that we have a very high degree of lateral coherence. So we have very high degree of lateral coherence and very high degree of temporal coherence due to the monochromatic beam. Well, this is the synchrotron radiation, and when you think at the synchrotron radiation facility, you have to think at a number of different laboratories, one close to the other. Because if this is the picture of the facility, this is a sketch of what happened into the facility. We have each of these lines are a beam line, which means each of these beam lines has been developed in order to exploit the different properties of synchrotron radiation. So so with each of these lines is a different laboratory. In electron, we have the CIRMAP beamline, that means synchrotron radiation for medical physics. And this is the beamline that has been developed in order to exploit X-ray imaging, especially for propagation-based imaging. So we, as Luigi introduced before, we perform a mammography study, and this is the patient support that we developed. Obviously, the study was in collaboration not only with the Elettra Synchrotron Trieste, which is the host institution, but also with the University Hospital of Trieste. So the beam is a stationary beam. The patient is in prone position. We have a picture of one patient. And here you see the breast compression system and the film screen and exposimeter system. The distance between breast and film is 1.6 meters. So the distance is large enough in order to let we be able to detect the interference pattern between the diffracted wave and the unperturbed wave. In order to acquire the breast, the mammography, we moved the patient and the film screen system in front of the beam. Why screen film? Because this is a 15-year-old study, and at the time of the study, the film was the only detector that allowed us a spatial resolution high enough in order to detect the interference pattern. The study, you see that the study was published about 10 years ago. The patient inclusion criteria: patient with questionable or suspicious breast abnormalities identified at combined digital mammography and ultrasonography. So only patient with doubtful diagnosis after the standard clinical exam, which means negative digital mammography, but presence of palpable mass not resolved by ultrasound in heterogeneously or homogeneously dense breast. We know that dense breast is a problem. Focal asymmetry of tissue density on digital mammography between two breasts not resolved by ultrasound. Architectural distortion in digital mammography not resolved by ultrasound, or suspicious abnormality in digital mammography consisting in equivocal of doubtful masses not resolved in ultrasound. This is a very short summary of our results. We asked to experienced radiologists to evaluate the evaluation of our images comparing the film screen and the phase contrast mammography. And the score is 1 if excellent visualization in digital mammography and poor visualization with propagation-based imaging. This 4 means equal visualization for both modalities, and 7 means excellent visualization with propagation-based imaging, poor visualization with digital mammography. You see that the result, we demonstrate that propagation-based imaging gives significantly better visibility of abnormalities. Even if we perform a statistical analysis according to the subgroups, we have a significant improvement for this architectural distortion and for masses. We have only very limited number of patients, including microcalcification, so we have no significant results, probably due to the small number of patients you see with microcalcification. Moreover, our study included 71 patients, and we calculate the receiver operating characteristic curve for in order to compare the mammography with synchrotron radiation and the digital mammography, and you see that the results of propagation-based imaging is much, much better. Please consider that, keep in mind the inclusion criteria, because we have such a poor ROC curves for digital mammography is due to the inclusion criteria. I mean, generally speaking, if we calculate a ROC curve for screening, the ROC curve of digital mammography is much, much better than this one. This is the ROC curve of our specific sample. Moreover, the mean glandular dose of propagation-based imaging exams are only the 60% of the dose in digital mammography. Probably this is not related to the phase contrast, but to the monochromaticity of the beam, because with monochromatic beam, we don't have the low energy component of the spectrum that deliver a lot of dose to the tissue without contribution to the imaging. But these are the results, so it's very encouraging results. Now we are working at the CIRMA3D project, which means a breast CT project. Again, the partner are the University Hospital, Elettra, and the two institutions of me and Luigi Rigon, so University of Trieste and the National Institute of Nuclear Physics. Here you see again our patient support. Our patient support was designed in order to be able to rotate around the axis, so it is feasible to perform CT. Here we have a photon counting detector, and here you see that we need to remove the patient support, obviously. In the CT project, we want to exploit not only the propagation-based imaging, but also the phase retrieval that can be also considered a sort of numerical back propagation of the data. But let me go step by step, and let me introduce our single photon counting detector. It is a cadmium telluride detector, and we are very happy, very proud of it because it has very high efficiency, large area, small pixel. The pixel is about 60 micron. We have direct conversion that we are working in that time free mode, so we are not losing any photons due to the that time of the electronics. And thanks to the tunable pressure, we are able to reject completely the electronic noise. So it's very powerful tool. Obviously, we have to pay something, and the point is that such a large active area, 25 centimeter, is obtained thanks to 8 modules that are one close to the other. So this multi-module architecture means that we have a 3 pixel gap between each modules. So we pay in a signal lag of a little bit more than 150 micron. Moreover, the cadmium telluride is not completely stable. It means that there are some charge trapping effects that change during the exposure time. So which means that we have some artifacts related to the long exposure time for CT. So it is necessary to develop a pre-processing that is dedicated exactly for this application and for this detector. And this is an example of what happened without pre-processing. You see that the artifacts due to the modules, and this is the image of a breast specimen acquired with 32 kV and a high mean glandular dose of 20 milligrams. So this is a sort of image of that is before what we can say before detector calibration. This is what usually say our manufacturer when they come to our digital radiology unit, when we call them due to some artifacts that are present in our system. Well, after the pre-processing, we get rid of the artifacts, and now we are ready for this is what in DICOM can be defined for processing images. So this image is free from artifacts due to the detector. And here you can also see that these brilliant signals that are edge enhancement due to the propagation-based imaging. And then we apply the phase retrieval. Professor Rigon introduced you the phase retrieval. Phase retrieval can be described as a low-pass filter in the 2D Fourier space. But this low-pass filter is designed according to physics, and so this is the formula, and so we have to consider the wavelength, we have to consider the sample to detector distance, and the delta beta, that are 2 parameters that are parameters of the tissue that is under investigation. Here you see this is a breast sample, and you can see the cut. These cuts were done by pathologists in order to let the formalin enter into the tissue and fix it. So this is the edge between fat and glandular tissue, and we assume that this is a sharp edge due to the clinical cut done by the pathologist. Well, here you see that the signal profile across this threshold without the phase retrieval. You see that we have a contrast to noise ratio that is 0.7, and the full width of maximum is not easy to calculate the full width of maximum of this step, but roughly, we calculate it in terms of 120 micron. After the phase retrieval, which means after the application of the filter that is designed according to physics and according to the physics of propagation-based imaging, This is the result. The result is the contrast to noise ratio that increase of a factor 10, and the full width of maximum, so which is the spatial resolution that is increased a little bit. So we increase the full width of maximum, we decrease a little bit the spatial resolution, though it is more or less a factor 2. You see that the improvement in the image is very, very much. We can appreciate very better the structure of the tissue. Another slide in order to give you an idea of the phase retrieval effectiveness. Here we see images acquired with increasing mean glandular dose, with phase retrieval and without phase retrieval. You see that even with very high mean glandular dose, the image quality is hardly comparable with the quality of the image obtained with very much lower mean glandular dose, but after the phase retrieval filtering. So some details in terms of material and methods about our breast mastectomy sample studies. So the sample to detector distance is 1.6 meters. This is the dimension of our radiological room, and we plan to extend this distance up to 4 meters. Our study was done at 32 kV, and 5 milligray is the mean glandular dose delivered. So 5 milligray because it is more or less 2 times the maximum dose associated to the single view mammography. So which means that we are in the range of clinical mammography in terms of dose. Cadmium telluride photon counting detector, the reconstructed voxel size is 57 by 57 by 50 microns. So we are working with a very small voxel size, much smaller than the cone beam breast CT system that are on the market. And since the synchrotron radiation beam have a negligible divergence, we collect a projection over 180 degrees. And okay, we apply the phase retrieval algorithm. In the Paganin is the author of the algorithm that we apply before the usual filter back projection reconstruction. So we are not applying in the images that I'm going to show you advanced iterative reconstruction techniques. We did a quantitative comparison between phase contrast breast CT and cone beam breast CT. Here these are the results. We have this. We use a test object developed for breast CT, and we acquired with the same delivered dose at the clinical system and at the synchrotron. As an example, here you see the calcification, the visibility of the calcification, and the improvement is quite evident. And generally speaking, we observed higher signal to noise ratio, higher spatial resolution, and finer granularity. If you are interested in the detail, this paper is open access, so you can find it easily. And now let me show you the 3D reconstruction of this movie. Let you see how can we visualize a breast in breast CT. Obviously, the radiologist needs a new training because the images are completely different than the conventional breast CT, but results are very impressive. Moreover, in this 3D reconstruction, the red dots are the microcalcification and gray is the granular tissue. Oops, I'm sorry. This is another way to show the same results if you want. Okay, this is the in vivo clinical mammography before surgery, and this is a macro calcification that we use as a reference point. This is a single slice in the same plane of the mammography, and this is the maximum intensity projection of the breast CT slices, and let we see that we detect a very large number of microcalcification, a number that is much higher than the microcalcification visible in digital mammography. And you know that the microcalcification are very important for radiologists in order to avoid grading the cancer. So even if we are performing spectral, we are performing CT, we are still at a very significant spatial resolution. Here you see a 3D view of a breast before surgery, and this is the in vivo mammography, and radiologists can compare the appearance of the information of mammography compared to the information that we obtain in 3D breast CT. Obviously, if you have 3D data set, you can perform 3D view and obtain a lot of interesting information. And moreover, CT images can be calibrated in terms of linear attenuation coefficient. Please pay attention that we are working with monochromatic beam. And so if we are working with monochromatic beam, we don't need the Ansfield Udin. We are able to calculate the linear attenuation coefficient. Here we have some reference in order to let we perform the calibration, but very soon we realize that we don't need external reference. We need in order to perform calibration. And here we have data of linear attenuation coefficient of glandular tissue, tumor, and adipose tissue. And this is the data that we acquired during the breast CT program in the energy range between 27 and 38 keV, compared with the data obtained in different studies. A few slides in order to show you the comparison of breast CT with histological images. Here, this is a breast CT, and this is the magnification of this detail. In the yellow line, define lesion with well-defined smooth margin encapsulated tumor. But it is also But it is also possible to see a different structure. This is a lesion with irregular margins, ductal structures, and papillary lesion. And you see that the shape is exactly the same. And in the blue line, we have the skin. This is another example. This example is a mastectomy containing an infiltrating lobular carcinoma. The lobular carcinoma is a challenge for our radiologists, and is a challenge also is a problem for surgery. And again, the slice with the lobular carcinoma, the magnification, the comparison with the histology. And please see that also some details that we see. This is the cancer, and here we have some details that are details containing cells. Well, they are visible both in the CT and in the histology. One more example. In this example, again, obviously these are mastectomy. So in mastectomy, the cancer is huge, but we can appreciate some detail because we can see the magnification of these detail. And this is a satellite nodules that is visible also in the histology, but it is also possible to see an expansive linear solid projection. You see, this is visible in histology, and it is visible in the breast CT. And this is an important detail because let we understand that we have an expansion that have to be removed during the surgery. So it's a malign indication of a malignant aggressive cancer. Well, what's in the future? We are not the only team working at the breast CT program at the synchrotron radiation facility. There is a twin program in Australia, the Australia Synchrotron Radiation Facility in Melbourne. They are working in breast CT. We have also a number of collaboration with them. Before COVID-19 pandemic condition, the first patient exam was expected by the end of this year, 2021. They are a little bit later as far as I know, the first patient is not scheduled yet, but they are quite close to this target. And this is about synchrotron radiation. But probably a lot of you are interested in the translational research toward clinical systems. I see also some comment during the Professor Rigon talk about a rating system and moving towards the clinics. Well, I wanted to present you 3 selected programs. One program about edge illumination, one program about grating interferometry for mammography, and moreover, some results about the first clinical study in grating interferometry lung imaging. And this would be the last step of our travel in the field of medical application of phase contrast imaging. So let me go from the edge illumination in edge illumination computed tomography. We are in London, in the University College of London, UK, and they have developed a system in order to perform edge illumination computed tomography scans in minutes. Here you see you remember edge illumination was presented by Professor Rigon. We need a mask sample and we need a sample mask and detector mask, because the idea is that the beam had to arrive on the detector at the edge of the mask. So the beam must be a little bit up on the detector and a little bit on the mask, in order to be able to detect the refraction of the beam due to the presence of the sample. Well, you see the dimension of this setup is of the order of 1 meter. So it's a large but not very large system. And they evaluated about 100 specimens, and the results were compared against the commercial system. Let me show you the results. So this is a recent paper published in Scientific Reports. The idea is to perform intraoperative breast imaging. Why? Because detection of margin involvement intraoperative during the intervention would allow the removal of additional tissue during the same intervention. So we are thinking about breast cancer, and what happened? It happened that in conservative surgery, they remove the cancer, and the problem is, are there any infiltrated margin still in the patient? Nowadays, what it is possible to do is to perform the radiography of the tissues with during this study they used the Faxitron, that is a commercial system, and this is a planar radiography. And this is what it is possible nowadays to do during the intervention. After the intervention, obviously, we have the histology, and we have to wait the histology in order to be sure that the removed tissue contain the full cancer, including the whole infiltrated margins. If histology says the removed tissue is not enough, it is necessary to recall the patient, and the patient has to go towards a second intervention. So this is under the clinical, this is not in vivo imaging, but it is a very important clinical problem. Well, what is the result? The result is that they are able, using this setup, they perform the CT of more than 100 specimens. And what we see that they are able to obtain very good quality CT images that was able to to see not only the cancer, but also the variation in tumor density and the infiltrated tumor margins, and moreover also some tumor-induced inflammation. Okay, if this image can be acquired during the intervention, could be a very important information for the medical doctor. So this is the state of the research at the best of my knowledge, in edge-illumination CT for clinical application. And then we move from UK, we can move to Swiss, because this is these images are courtesy of Professor Marco Stampanoni, who works in the Paul Schering Institute that is near to Zurich, and it is also professor of the Technical University of Zurich. He works in grating interferometry for breast imaging. You remember more or less the technique was introduced by Professor Rigon. Using grating interferometry, it's possible to acquire absorption mammography to perform the reconstruction of the phase contrast images, and it is also possible to study the small angle scattering. And some years ago, there was a very exciting results about the possibility of characterize the microcalcification according their scattering properties. Well, Professor Stampanoni and his colleagues, they developed a grating interferometry device for mammography. The starting point was the Sectra Philips photon counting mammography system. It is a mammography system that works in a scanning mode from left to right with using the silicon microstrip detector. And what they do, they added between the breast compressor and the detector a compact, what they call a compact interferometer. So we have G1 and G2, the two grating systems, and the G0, the grating that it is necessary in front of the X-ray tube, because obviously it is not, we have not spatial coherence with the conventional X-ray tube. What happened? It happened that they performed a study with mastectomy. The results are a good one. It's very much encouraging. And at the best of my knowledge, they are not running now patient, but they are quite close to be able to run in vivo mammography. Obviously, in their plan, there is also a 3D breast imaging, but first of all, I'm waiting for the mammography device, because you can, obviously you have clear in your mind that if you run breast CT, which means that you have to move the grating system, that have to be aligned with the tolerance of a few microns, this system with very fine alignment that have to rotate around the patient, while in the edge illumination CT of the sample is the sample that rotates and not the grating system. But this is another interesting research that is close to application. And now this is my last slide. Is in Munich, the professor Franz Pfeiffer developed the first clinical study in grating interferometry lung study. So this is what happened. He developed again the system with gratings, G0, G1, the three system of the grating, and it is able to acquire the images line by line, and after data processing, obtain the conventional X-ray and the dark field or small angle scattering. That's important because we are we are back to the lungs. Exactly, we are back to the first slides of Professor Rigon. Okay, the data acquisition in about 7 seconds. The effective dose is more or less 2 times the effective dose of a conventional X-ray exam, chest exam, and 77 patients with different disease stages. But what is the disease? Chronic obstructive pulmonary disease, and was the disease. Let me show you the setup. This is the setup that was used, and this is the setup used also during the COVID emergency in order to investigate COVID patients. And this is the results. This is the dark field. Dark field means small angle scattering, and this is this is dark field, and this is conventional. You see that the conventional images is more or less the same. We are not. I am not a medical doctor, so I'm not a radiologist. I cannot say that I don't see any differences. While I see that moving from A to L, the signal in the dark field is completely different, and this is why. A is almost normal, and L is a severe emphysema. And what happened? It happened that with a decline in the number of alveolar interfaces, less small angle scattering is induced, resulting in decreasing dark field signal values. So, which means that we are the evidence of the emphysema is quite evident. So it's very much very promising. So in summary, the future of medical imaging technology, this was the title that our conveners decided for this webinar. What I can say the phase contrast imaging is a family of techniques that have been applied in low contrast images. Okay, synchrotron radiation beamlines are the first choice. I have to say that also Professor Olivo, Professor Stampanoni, Professor Pfeiffer started their research in synchrotron radiation facilities. And this is the first choice because to collect useful information to subsequent clinical translation and also to provide the ultimate proof that methodologies yield clinical advantages. And then we can say that few clinical studies and important clinical applications demonstrate that the phase contrast can contribute significantly to the future of medical imaging technology. Devices to be used in the hospital are under development in different research groups and in collaboration with industrial partners. I think that the industrial partners are very important because these 3 examples that I discussed with you, each of these have an industrial partner, and which means that the development of products to be available in the market is probably in the future, in the near future. I thank you for your attention.
Thank you very much, dear Professor Longo, for your nice presentation and also valuable insight about application of this X-ray phase contrast imaging in mammography. Thank you. Now, if you agree, the session will be open for questions. We have some question in chat box, but I think if they wish, they can raise their hand and they will have time to ask their question online. No question? Okay, then I think I can ask from the chat box what it is written. Mr. Mortaza, ask about let me read it exactly. Ask about that why these non-crystal detectors are not found in the market or by other world, why it's not popular. I think it was the question which was asked in the first session of the webinar. Okay.
Yes, so I try to answer. Well, in general, the question I think relates to the role of the detector in these X-ray phase contrast imaging techniques. The role of the detector, well, for some applications, the detector doesn't do anything special. I mean, for instance, the phase contrast images I show you, the one with the mimosa flower, were taken with a high resolution film. And also the clinical program that we made here in Trieste was performed with a conventional screen film cassette. So in general, I mean, for some techniques, the detector doesn't have any particular requirements. In the case of propagation-based imaging, the only important thing is that the detector has a good enough spatial resolution. Now, if you move to edge illumination techniques, then the detector can be important. In particular, it's important a good match between the detector and the setup. So for instance, the detector mask in the edge illumination setup is must be really tailored on the detector because it must have the same pitch of the pixel size of the detector. Anyway, except for this, I mean, you can do with every detector. I mean, you can do it with CCDs, we can do it with flat panels. You can do, well, probably the best choice would be some hybrid detectors, maybe like the one that we used here in Trieste, the PCI detector. These actually are prototypes that are not really widespread on the market, but the technology is ready, I guess. So, I mean, the advantage of this detector is that they have very little crosstalk between neighboring pixels. So if you want to separate the signal coming from several beamlights, it's important that you don't have crosstalk between pixels. But I think, yeah, I mean, the technology is ready. If there is enough interest in the market, then it could be easily produced. The detector will not be the bottleneck, let's say, of this technology. According, yeah, this is my opinion.
Great, thank you for your answer. Another question, it is, I think it is Miss Rezvan asked about, this is the photon counting mammography system microdose. Is this, I think it is a question.
Yes, yes. Microdose is a system that is based on silicon strip detector. So it's the silicon strip detector is aligned with the incoming radiation, and then it performs the scan during the scan of the breast during the acquisition. It was developed by Secta, that was a small company in Sweden. Then it was acquired by Philips Medical System. And it seems to me that it is, I'm not sure that it is still on the market, but it was the first system with photon counting detector on the market.
Great, thank you. Another question from Mortaza, I think. Is there any device right now for CT breast?
Yes, there are a couple of, I'm sorry, Luigi.
No, go ahead.
There are a couple of devices on the market. One is, there are two systems with the cone beam CT, so which means a large beam that, and only the full breast, the full CT are acquired with only one rotation of the system around the breast. And then there is another one that is based on the photon counting detector, and it works in a spiral CT. Both of them are from small company, and to be honest, they are not very popular, but they are.
Okay, great.
Anyway, they don't use phase contrast at the moment. I mean, they are just absorption-based breast CT. So this is why our system had this dramatic advantage with respect to the commercial. Anyway, they have been FDA approved, and so in principle, they can be used, right? Now, the challenge is, if possible, to translate some phase contrast in it. That would be really a breakthrough, to have a phase contrast clinical breast CT system.
Great, great. Thank you for your answer. And I have no idea if I am reading the Dr. Fatiha Hassan. I think I hope that I read her name correctly. Ask, dear Dr. Renata, can we join your team, the breast project?
Can you?
Can I think they wish to join your research team.
As an international cooperation, or I don't know, we have to discuss, to be honest. I mean that we have the PhD position in Italy are open once per year, and there is a selection. It's a competitive selection, so it's not a choice of the professor. And in this moment, I think that we don't have a postdoc position, but okay, I think that we have to discuss. Generally speaking, in this moment, we have not open position.
Okay, great. It just I'm reading the. I think we have answered all the question which was written in the chat box. Again, I think just a few minutes. If anyone else wish to talk or ask question, they can raise hand and ask their question online. If not, as a tradition in our webinar, our participant, if they wish, they can turn on their webcam and to take a memorial photo from this webinar. Okay, great. First one.
Well, it's a nice tradition. I like it.
Okay, we are waiting for the other.
Yeah.
Great. شما سنگیتون رو بیارین جلو بیارین شما که بذار من این ماست غیر فعال کنم. این دور بیارم. Okay, little by little, our participants are joining us, and
So we switch to gallery view.
yeah,
To take the picture.
yeah, great. Okay, just I use this moment and I want to introduce my colleagues. Dr. Professor Changizi, he's the head of our department. And Dr. Jazairi is my colleague in radiation science department.
It's a pleasure. It's really a great pleasure to meet all of you.
Yeah, and thanks again
for a nice presentation. Thank you very much.
Thank you very much. Your presentation.
Thank you for the invitation, actually. Faride, I've seen that somebody is asking the slides of the presentation, so I think we have no problems to share them. Maybe later I will send you a link with the email, and then you can, if you want to make them available, it's no problem.
Great, thank you, thank you. But just something which I must mention as the last one, that is that this the movie of this presentation will be available in YouTube.
Okay, that's great.
Thank you so much. Okay, just I think no more participants wish to share their photos with their webcam with us, let's just make it, excuse me, just a screenshot. Thank you. No, just we are, someone else are joining. Then wait some minutes, excuse me. Just wait
Okay.
for others. Mhm. Okay. Then here, I think we come to the end of this webinar. I must say thank you to everyone who made this webinar possible. It's my special thank to dear Professor Longo and dear Professor Rigon for their nice collaboration and kind, I don't know, kind collaboration, nice and kind collaboration. I appreciate your effort for this webinar. I hope everybody use as a lot from this webinar, and hope to see you again.
Okay.
If Professor Rigon and Professor Longo, if you have anything to add to the webinar, we can have it.
Okay, thanks again.
Thanks again.
Okay, we keep in touch, let's say, if you need a slide, but if you have the video, probably that's enough. Anyway, thanks again for this opportunity. It was really a pleasure to speak in front of such an international audience. Yeah, thanks again.
Okay. Thank you again. See you. Bye-bye.
Thank you.
Thank you.
Bye.
See you.
Thank
Bye.
you.
Goodbye.
Bye.
خسته نباشید. دست در نکنه.
سلامت باشین. ممنون.